Dr. Rajib is asking is in case of growth failure or syndromic patient, is it necessary to do workup like TTG, GS levels, etc.? Of course not. If you have a clear-cut syndrome which is there, if you have somebody who looks like achondroplasia, don't do unnecessary workup. So that evaluation will come first even before screening. So if you have abnormal facies, you don't need to work up on that in that regards. And GH and all should not, of course, be done in a clear-cut syndromic case. About one condition where growth becomes very relevant, which is the SGA. And SGA is a classical situation of what we can say the Sita Gita story, in which you have got some children who will catch up very fast and have problems, and others who will not catch up and will have a problem. So when we talk about SGA, it's actually a mixed bag. We'll discuss about that. There will be around 20% children who have a slow growth, they develop early puberty, and then land up short. They don't have metabolic complications. But then there are around 30% who will have a rapid growth, they will have weight gain, and they will develop metabolic complications like diabetes, polycystic ovary disease, and other complications. So when we talk about SGA, endocrine parameters are absolutely important to evaluate. Otherwise, there will be a confusion which may happen in this perspective. This is important, and therefore we need to be careful, and all the pediatricians and neonatologists should be aware about that, and that becomes relevant in that setting. So what really is SGA? SGA is common. It is a statistical definition 2.5%, and 10% of all short adults are actually SGA. So SGA is 4 times likely to cause short adult height in that regards, and very common in terms of Indian perspective. As discussed, slow growth, short stature, rapid growth, metabolic syndrome. So this is how you have to balance between the two, and that's why monitoring becomes important. Now, what is the difference between SGA and IOGR? Dr. Anurag, is there a difference you think?
There's a difference.
Yeah. So SGA is actually a single picture, whether you are short at birth or not, while IOGR is a continuous film. So it's like a snapshot or a film. SGA means you are short at birth or not, while IOGR will mean whether your growth is restricted or not. So what we are actually worried about is IOGR. But since we don't have follow-up data in most cases, we talk about birth weight as the most important parameter. So we can have, like this child, you can see, he has been continuously below, he's growing normally, but he is SGA, he is not IOGR. His growth is normal, but he is short. You can have somebody who is both SGA and IOGR, and you can have somebody who is IOGR, but not SGA because his parents are bigger. So as we talked about in growth failure, that somebody could be very short and not growing at all. So similar picture can happen here. Ideally, you should have an ultrasound data which will tell you whether the child was growing well or not. But if it is not available, look at the birth weight. That is the most important parameter to go for in that regards. Now, very importantly, preterm babies also will have a low birth weight. There also you have to follow them up with the same parameters. Till term, you follow them on the intrauterine growth chart. Now, which intrauterine growth chart will you like to follow, Dr. Prateek? So now there are multiple, as WHO has come up charts with older children, it has also come up with an intergrowth study, which provides good multinational data. So that should be the one in which you should plot it. And after 1 year, you don't need to correct. Now, what causes SGA? The problem could be in the mother. So like it could be malnutrition, it could be anemia, it could be PIH, it could be diabetes, it could be placental problems, particularly the eclampsia, which will be there. If there is a maternal or placental problem, the baby is living in a bad situation, bad environment. As soon as the baby comes out, growth becomes normal. So there is a rapid catch-up. But if there is an intrinsic fetal problem, the catch-up will be poor. Now, what proportion, Dr. Naveen, do you think children do not catch up? 10 to 20%, and by what age they should catch up? So usually by around even 1 year to 2 years, they will catch up. So we talked about catch down growth in the first case. Here it is catch up. Catch up should happen by 1 to 2 years, but we tend to wait till 4 years if there is malnutrition. Otherwise, USA, they'll talk about wait for 2 years. Europe, 4 years. India may be more if somebody is malnourished, but if somebody is not catching up by 2 years, he's going to be short. This is something you need to be aware about in that regards. So the main endocrine issues in SGA is short stature, early puberty, and metabolic complications. So we'll see how it goes and how we go forward in that perspective. So what causes short stature in SGA is basically that there is a high level of growth hormone in the fetal period, which causes a growth hormone resistance like state. It is like a malnutrition state, and this persists subsequently. So postnatally, growth hormone is not working. So their growth hormone levels are normal, but they are resistant to growth hormone, and they would definitely require a careful evaluation because they often have early puberty, which causes less time for them to grow and fusion happens. Sometimes you can have a syndromic association. Dr. Tambe, which syndrome do you think this child is? This is the most common cause of syndromic SGA who don't have catch-up. Turners usually don't have that much low birth weight. If you look at the faces, there is a asymmetry. The facial asymmetry is there. This child also had clinodectally. So this is a classical picture of Silver Russell syndrome. If you have anybody who is SGA, look for the faces, whether the face is asymmetrical or not. That could be Silver Russell in that regard, which can cause this in that perspective. So this is what we are talking about. Most children will catch up by around 1 year of age. If they are not catching by 1 to 2 years of age, don't wait. You can't keep on waiting till ever, because then there could be a problem in terms of time being less, and there could be more complications which are there in that perspective. So now we have got this 5-year-old boy who had poor growth, normal development, height is low, and weight is low. So what do you think will happen here? Manoj, do you think this child requires follow-up? So this is a time, if he has not caught up here, something has to be done. Otherwise, he'll be short throughout. Now, what should be done? And this is clearly shown. This is the consensus statement from the SGA, which says that first you exclude the chronic diseases. So of course, you have to rule out renal failure, liver disease, creatinine, and all those parameters have to go. Work up on nutrition. Very important from Indian perspective that nutrition has to be built up. Very importantly, you have to think of contraindications to growth hormone. What is the absolute contraindication to growth hormone, Dr. Sayan? So, yeah, Down syndrome, very importantly. If somebody has Down syndrome, there is a risk of malignancy. You should never give growth hormone in that setting. Similarly, all the chromosome Beckett syndrome, pre-neoplastic syndrome should not be given growth hormone. So you have to think of these things like Fanconi, Bloom's, ataxia, and then you do not need GH testing. It may help you, but it is not essential. And what you're doing is that you give a high dose of growth hormone, and there will be a good response which will happen in that perspective. So I would summarize that if you have a short child who was SGA, not catching by 4 years of age, I would be more inclined toward treating. The worse the height, the better would be the outcome. If he's borderline, we can follow up maybe for some time, but otherwise be wary of puberty, which becomes very, very important in that regards. Now, what happens to this in terms of treatment is, it is a very safe treatment, but we have to monitor for a few problems. There is a protein retention which happens initially, so there can be some edema to begin with. There could be pressure in, again, the edema will cause benign intracranial hypertension, which may happen. Hypothyroidism may be unmasked. Rarely, if the growth is very rapid, there could be a slipped epiphysis which may happen. Glucose intolerance and tumorigenesis are rare. So it's a safe therapy overall, but should be given with caution in that perspective. And therefore, you will have evaluation and impact. Now, this is the Indian data. Western data says that if you treat for every 1 year of treatment, you would be gaining around 1.5 centimeters per year. So if you treat for 5 years, you will get an extra 7 to 8 centimeters. But it's an expensive treatment. So you have to be cautious in that regards, that you have to explain them that this is the response. For GHD, the response is much better. SGA, the response is slightly less, but again, a good response. This is the Indian data from Dr. Khadilkar's group, which also talks about a good response in Indian children also in that regards. And this is a good response which we have observed. The cost is significant. So you have to individualize the decision. Do not treat everybody with SGA, but SGA very short, explain the cost and then treat. That is what we talk about. Russell-Silver syndrome have a good response to treatment as with other SGA. The next big issue is about puberty. Now they have got double whammy. They will have short stature on one hand and early puberty on the other. So if you have early puberty, what will be the problem, Dr. Vibha, in terms of growth? So they will have less time to grow. One, they are growing slow and their bone age is fast, so they will fuse quickly. So this is a big problem which happens. So if you have a SGA with early puberty, immediately rush for management. If you have an obese child with early puberty, plus minus, they may be tall, then you have to evaluate. Less than 6 years of age, anyway, you have to evaluate and manage. 6 to 8 years with SGA, I will say immediately evaluation. 6 to 8 with obesity, plus minus, look at the height, and then you have to evaluate. So puberty tends to happen early in this setting, and this is a big problem which is there. And this is what has been shown, that typically these children will be tall to begin, even will be short, and their puberty happens early, their bones will fuse quickly. So this is an important consideration to worry about. So we have an 11-year-old boy, birth weight was low, now there is growth concern, and what's happening is that there is a stage 3 pubic hair and testicular volume is 6 ml. So what do you think, Pratik, is happening here?
We have a birth weight of 2.4 kg. After that, he has attained puberty high. Now the thing is, if a normal boy was there, I would have worried. But since he's SGA, he's already attained puberty. That increases the metabolic complication.
And also he will remain short if we don't treat, because he's short and he's already entered into puberty. So as discussed, this is some situation, bone age is already 12.5 years. So he's lost 1.5 years already. So what we can do in this setting is actually to do something for the puberty. So what we can do for early puberty is we can give a GnRH analog. If it is a central precocious puberty, we can delay the puberty in that perspective. And studies have clearly shown that in individuals who have early puberty and SGA, GnRH analogs do improve the height in that perspective. Now, 6.5-year-old, this is another big problem we see. She presented to us with precautious pubarchy. Now, pubarchy is becoming more common, and girls with SGA have an early tendency of having pubarchy. The big problem is that those who have pubarchy tend to develop polycystic ovarian syndrome later on. So if you have precautious pubarchy, be wary in that setting. So what's happening here is that pubic hair is there, stage 3. DHEAS is high. This is a precautious pubarchy. What can we do in this setting? So what is the cause of precautious pubarchy first, Dr. Naveen, in this setting?
Basically, what we need insulin resistance, adipose tissue, and this basically low in case of a SGA. So what basically happens is that get accumulated in the other sites such as liver, which is input to insulin resistance, and that is basically.
So basically, SGA have a metabolic syndrome and they develop insulin resistance, which is causing precautious pubarchy. So what can we do in this setting? We can give metformin in this setting, which will improve. So SGA with precautious pubarchy, there are studies which show that metformin will delay pubertal progression and they will increase height also in that regard, which is available. And this is the study that we're talking about in terms of metformin. It improves the outcome and significant increase in height may happen. So we now, if we have a SGA girl with precautious puberty and short stature, do think of metformin as a possibility of treatment, which becomes important. The final situation is, what about metabolic complication or adiposity, and how does it really impact in that perspective? Now, Naveen had explained it very nicely. Whatever fat we take in is deposited in our subcutaneous tissue. Now, all of us have got a fixed amount of subcutaneous fat which we can store. If we have got more than that fat, it goes into the liver. It's a very simplistic way to think of it, but this is the way. You either have a cutaneous fat or a visceral fat. So if your fat exceeds, it goes to the liver, the pancreas, the kidney, other places as well. And that causes insulin resistance and all the complications. It will cause fatty liver, insulin resistance will happen, you will develop diabetes, you will develop PCOS, hypertension, everything. So essentially, the problem with obesity is that you have got more fat than you can store. Now, what's the problem with SGA? Their ability to store is limited. So if you have a 2 kg child, they can store only a limited amount of fat. A 4 kg child can have a much bigger fat. So if suppose that 2 kg becomes 50 kg or 60 kgs, he will have much more complication than somebody who was 4 kg develops 80 kg also. So if you are SGA, you cannot afford to become obese because that's going to cause more problem. LGA becoming obese will have less problem. And that is why we talk about Indian individuals who develop diabetes at lesser weight. This is the basic concept, that you can't store the fat properly. And that's the problem which happens. So this will cause small fat store, rapid weight gain, spill over, and this will cause all the problems which is happening in that regards. And this has come from a large study from Pune, which clearly showed again that small for birth and large at 22 years, highest risk of metabolic complications. So this is something which we are seeing a lot. SGA is the most important predictor in that setting, which is there in that regards. And this again is a big study which shows the similar picture in that regard. This is our study in which we looked at that many obese children do not develop metabolic complications. So we wanted to look what are the causes of that. And what we found interestingly was that low birth weight was a big predictor of metabolic complication. If an obese child had a low birth weight, he is much more likely to have metabolic complications. So again, same concept of SGA, which becomes important. So what can we do? One, of course, is reduce intake. Second, of course, is exclusive breastfeeding, which is very, very important for at least 6 months. Monitor very carefully. Look for adiposity. Theoretically, you can use leptin sensitizers and TZDs, which is not a practical issue, but definitely you can think of metformin. So if there is fatty liver disease, if there is prediabetes, if there is dyslipidemia, precautious puberty, obesity, SGA, think of metformin, it will help. Early metformin will help more in that setting. So just to summarize, SGA is common. They will have a tendency of either growing too little and remaining short, or they will have a rapid growth and they will land up to be having metabolic complications. Do not be aggressive. Often parents say that feed more, feed more. This is the main phenomena. This child is small, we will need to feed more. We should avoid that. Go slow in that regards. Watch for BMI in puberty carefully in that regards. Timely intervention for growth. By around 4 years, if they are short, start thinking of evaluation. Pediatric endocrine referral will become important. Look for BMI, getting obese, think of glucose tolerance, think of SGPT, think of the lipid profile, which will help you out. And this is how it will help from that perspective. So I think we'll close at that point of time and take any questions. You can all have a look at our website, in which there are a lot of information available and many courses are available. The application can be downloadable from the iOS and the Android store as well. And the books are available also. So actually, IOGR is a very simplistic term that the fetus is not growing. That what basically means. Now, this IOGR can be because of undernutrition in the placenta. It may be because of intrinsic factors. It may be because of whatever reasons. So what I can say is that as we say growth failure, now growth failure may be because of malnutrition. It may be endocrine. It may be some other causes. So IOGR is a blanket term. It just means that the rate of growth is less than what we want to achieve in that perspective. Now, it may be undernutrition as well, which may be the most common cause, but there can be other factors as well in that regards. So actually, when we talk about all this that we talked about, short stature, we talked about metabolic complication, they are mainly for IOGR. But since we cannot have the data of IOGR everybody, and most IOGR will be SGA also, we use a birth weight as a single parameter to assess for. But if we have got data, IOGR is a better predictor of long-term complications in that regards. And if you have a preterm IOGR, it is a multiplicative effect. The effect will be worse in that perspective. So if there are any questions we like to have on the chat box as well. So I think there are a few questions. Dr. Rajesh Joshi, your patient of 6.5 years, SG and precautious puberty and advanced pain age, you had suggested metformin, but approval is about 8 years. Can we use aromatase inhibitors? So this is a very, very interesting point, Dr. Rajesh. What we are saying is that this is really based upon the studies which are available. So this we discussed with the parent that this is not an approved drug at the moment, but we are using it based upon the research evidence which is there. Aromatase inhibitors, I would be not using in girls, because if you use aromatase inhibitors, the androgen levels will go up. And that is going to cause a lot of problems. Of course, it's not desirable in that setting. So aromatase inhibitors, definitely not in girls. For boys also, even we have shown in our own study in experimental data, which I did in Australia, clearly showed that aromatase inhibitors have a bad effect on bone, bad effect on prostate, bad effect on testis in boys. So we don't want to use that in that perspective. So yes, The use of metformin is experimental, but you have to discuss with the family. We have found good response once we have a discussion and consent in that perspective, in that regards, Dr. Rajesh.